Hello, my name is Georgopoulos Vasileios. I am a postgraduate student of physiotherapy on the course of manual therapy in the University of Nottingham. In the next 10 minutes, I will present the McKenzie approach. By the end of this video presentation, the viewer will be aware of the origin of the approach, of the fundamental principles and objectives of the method, of the nomenclature and the terminology of the approach, its strengths, its limitations, and what are the future suggestions of the literature. The story of the method is that in 1958 in New Zealand, a patient with leg pain visited Robin McKenzie in a physiotherapy clinic. While he was being examined, he adopted inadvertently an extension position while he was lying prone. He maintained this position for 10 minutes. That's the original position. And then, after that period of time, he reported that the leg pain was significantly improved and that in fact had not felt this good for weeks. Mackenzie was surprised, and immediately he began experimenting with the effects of sustained positions and end-range repeated movements of the lumbar spine on spinal symptoms. Through the years, the basic principles of the method were formed. After many years of experimentation in extension and flexion positions, there was a significant amount of feedback regarding patterns of pain behavior in this position, which led to the formation of a classification system for many spinal problems. Till then, it appears that clinicians, when assessed with chronic low back pain, they instructed their patients to move only once towards flexion and extension, leading to the assumption that these movements are painful and harmful. However, diagnosis may often be inconclusive unless an end-range movement is repeated multiple times in order to ease the starting painful symptoms. The assessment of this method aims in the identification of patients and their subsequent classification into subgroups according to the behavior of their symptoms when they are subjected to specific directions during the physical examination. The classification of patients into subgroups then can define the appropriate treatment. Using the assessment findings, the patients are classified into one of the three McKenzie syndromes. The first is the derangement syndrome, which is the most prevalent and is characterized by either decentralization or peripheralization of the symptoms in response to repeated movement or sustained postures within the physical examination. The second is the dysfunction syndrome, and the third is the postural syndrome. Under rare circumstances that the patient's symptoms after the initial assessment doesn't fit in any category, then the other group is being used. When the physical examination is done, directional preference is identified, and the patient has been classified into a group, then the advised treatment includes frequent repetitions of the specific end-range movement that eases the symptoms and matches the patient's directional preference. The most important objective of the McKenzie method is patient self-management. However, this objective includes three important phases. The first phase includes patient education and demonstration of how the end-range movements and the instructed position can affect their symptoms in a beneficial manner. At the same time, it's paramount for the patient to understand how the opposite directions aggravate their symptoms. Second phase is about educating patients in how to maintain the reduction and abolition of their symptoms, and the third phase is about education of the patient in how to restore full function to the lumbar spine without the appearance of the symptoms. But what all these terms regarding syndromes and effects means? The derangement syndrome is characterized by the centralization and peripheralization of symptoms in response to repeated movements or sustained postures of the lumbar spine. Furthermore, it helps classify a patient's derangement into posterior or anterior according to the directional preference. Regarding a definition for centralization, quoting McKenzie and May, centralization occurs in response to therapeutic loading strategies. Pain is progressively abolished in a distal to proximal direction, with each progressive abolition being retained over time until all symptoms are abolished. If back pain only is present, this moves from a widespread to a more central location and then is abolished. That's the picture of centralization. Peripheralization, on the other hand, is the exact opposite behavior of the symptoms, and directional preference defines the type of movement that eases the patient's pain, and it is used to direct the treatment exercises. The dysfunction syndrome can be found only in patients with chronic symptoms, and it is further characterized by intermittent spinal pain that is produced at the end range of a restricted movement. In contrast with derangement syndrome, the treatment consists of mobilization exercises towards the direction of movement that reproduces the pain. The postural syndrome is typically not seen in chronic low back pain and is characterized by intermittent but often midline or symmetrical spinal pain, which is produced by static sitting, positioning, and abolisis when the posture is corrected. The treatment of choice in this situation is the education of the patient and avoidance of the movements or positions that provoke pain. The other group is used only after extensive assessment that could span in many days and no syndrome could be identified. That patient is then referred for further medical examination. Regarding the strength and the efficiency of the method, it is important to mention that one characteristic of this approach is the individualized treatment that the patients receive. Also, there is evidence that this type of treatment is more effective than a generic treatment. Also, centralization can be reliably assessed and can be used to guide treatment. Furthermore, studies have shown that centralization can be a useful prognostic indicator and it's related with a good outcome without surgical treatment. On the other hand, peripheralization may indicate minimal nerve root impeachment, which consequently may lead to surgery. Now, under the scope of assessment, centralization seems to be more reliable than other common procedures such as palpation or observation. It appears that there is high proportion, close to 90%, in the classification of the patients into one of the syndromes, with 73% of them being further subclassified in the derangement syndrome. So far, there are no reported side effects or other unfavorable outcomes regarding this approach and its assessment. Moreover, failure to achieve centralization is a strong indicator of negative prognosis and poor results regarding back pain. The McKenzie method short-term pain relief is a common outcome, which leads to higher return to work rates and greater functional improvement. When McKenzie method is compared to other assessment procedures, it appears to produce better short-term outcomes than non-specific care and equal or slightly better outcomes than stabilization or strengthening exercise for patients with chronic low back pain. On the first glance, the McKenzie approach seems to be a very promising method and one that can be used for everything. However, as in every method, there are certain limitations. There are not enough data to suggest any long-term effect or benefit of the McKenzie approach on low back pain. To this day, there are no trials comparing the McKenzie method to placebo or to no treatment at all. Furthermore, centralization tends to be common but with decreased prevalence as the patient ages and their symptoms become more chronic. This limits its effectiveness to younger people and to mostly acute low back pain. Apparently, there is a form of uncertainty among studies and researchers about the existence of centralization. This is clearly a limitation. The McKenzie method demands extensive training and a significant amount of hours in order to be delivered appropriately to the patient and for the best outcome to be extracted. It appears that the definition of centralization given by McKenzie in 1981 is clear. However, there are difficulties in several studies on the perception of centralization and the type of subjects included and excluded from trials. At the same time, there are differences in the proportion of centralization between patients with acute and chronic low back pain. This indicates that the method is mostly effective on patients with acute low back pain, thus limiting the range of patients. Regarding specific conditions, it is well documented that the symptoms of spinal stenosis improve with forward bending and worsen upon extension. Similarly, the diameter of the foramina decreases in extension of the spine on patients with foraminal stenosis. These facts severely limit the usefulness of the method to specific conditions. Finally, the McKenzie assessment takes approximately 45 minutes to be completed. Centralization may develop after several days following the initial assessment. This possibility makes the method time-consuming. The McKenzie method is a frequently used approach, while the centralization phenomenon was first described 30 years ago. Even though there is effectiveness and a degree of reliability in the method, future researchers should make certain steps toward the evolution and the scientific completion of the method. The literature suggestions, briefly, are the establishment of standard documentation procedure for the identification of centralization. Centralization should be monitored routinely during spinal assessments and be used to guide treatment strategies. And finally, suggestions are made that the research must try to approach psychosocial factors because they are related with chronic low back pain and consequently with failure in achieving centralization. These are the references. Thank you for watching.